Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, and I am here to discuss health and disability in humanities with a special emphasis on the introduction to narrative medicine. We all know that how medical humanities emerged slowly, gradually with narrative medicine and then health humanities. So narrative medicine is one of the very important aspects of medical or health humanities. So let us see what is narrative medicine. So narrative medicine is a clinical approach that emphasizes the importance of patient and physician stories in the healing process to improve health outcomes and provide well-being. That is why this is called narrative. Narrative means a storytelling, expression, fiction, tale a tale. So coined in 2000 by Rita Sharon at Columbia University, it is defined as clinical practice that moves the focus from fixing a problem to understanding an experience using narrative competence, that is, the ability to recognize, interpret, and be moved by the plights of others and by the stories of illness to guide medical action. Furthermore, narrative medicine has emerged in response to a commodified health care system that places corporate and bureaucratic concerns over the need of the patient. Generated from a confluence of sources including humanities and medicine, primary care medicine, narratology, and the study of doctor-patient relationships, narrative medicine is medicine practiced with the competence to recognize, absorb, interpret, and be moved by the stories of illness. By placing events in temporal order with beginnings, middles, and ends, and by establishing connections among things using metaphor and figural language, narrative medicine helps doctors to recognize patients and disease and convey knowledge. They also help accompany patients through the ordeals of illness, and according to Rita Chiron, narrative medicine can ultimately lead to more humane, ethical, and effective health care. Now, let us see the core functions and purpose of narrative medicine. Now, patient stories fulfill several critical roles in modern healthcare. And in that, the first point is providing context. They help clinicians see the patient as a whole person, that is, John the grandfather and businessman, rather than just a diagnosis in a specific room. Establishing meaning, I'm talking about the core of narratives. So, one is providing context, the other is establishing meaning. A narrative arc provides coherence to the disorienting experience of getting sick, helping patients, make sense of biographical disruptions. Then comes informing diagnosis. Stories can reveal subtle symptoms or social determinants of health that a checklist might miss, leading to more accurate clinical conclusions. Then comes fostering empathy. Listening to these accounts is the foundation for compassionate care, helping physicians absorb, interpret, and be moved by another's suffering. If we talk of impact of narrative medicine on healthcare, the first come improved communication. Because improved communication bridges the gap between clinicians and patients, facilitating a more compassionate and open dialogue. Then, if we talk of another factor, this is enhanced education. So, medical students and professionals can gain deeper insights into patient experiences through case studies and narratives. And case studies helps immensely, deciphering the patient's mental state. Then comes empowerment. Patient and family storytelling can be used to improve healthcare qualified by amplifying the patient voice in decision making. So, what are the key practices of narrative medicine? The discipline uses techniques borrowed from the humanities to improve medical care, are close reading or listening, training clinicians to pay deep attention to a patient's words, silences, and body language to find the hidden story behind a physical complaint. Then, reflective writing. Practitioners often keep a parallel chart, a separate personal record where they write about their feelings and reflections on a patient, encounter to process the emotional weight of their work. Then, co creation, which tells us about the working with the patient to build a shared understanding of their health journey, which can improve treatment, adherence, and trust. Now, one of the main tenets of narrative medicine is close reading. Readers can examine points of view to enhance our understanding of Carroll's first, second, and third person perspective, which I'm going to discuss in detail. In telling a story, at the most basic level, there are three possible points of view. When one reads in the first person, one is reading a story through the eye of a particular character or narrator. The second person point of view for the reader is perhaps the most intimate because the you implicates the reader. Reading through one's own eye in the text, and she can either accept or reject the implication. The third person point of view, by contrast, seems to be the most objective, with the he and she providing a sort of new quality read. It is at this third person level where the reader can experience a limited or fully omniscient point of view. There is the possibility of moving beyond the spatiotemporal singularity of the first and second point of views. It is also important to note that the experiences of health and illness also begin with a storytelling. When we express our ailments to someone, such as a medical professional, we share a narrative about our physical experiences while feeling unwell. Even the decision to seek help involves telling ourselves a story to understand our condition. Once we engage in conversation with the medical professional, this narrative shifts into an information exchange. For instance, Anamasius refers to the medical professional's process of understanding and documenting our state of illness, which brings our personal story into the context of medical knowledge. Thus, the experience of health and illness not only represents our individual stories, but also plays a role in medical epistemology through diagnosis and treatment, which are inherently narrative in their descriptive nature. So, what are the core principles and movements of narrative medicine? The discipline, as we discussed earlier, also pioneered by Rita Sharon in 2000, centers on three core movements. First is attention, the capacity to listen with intensity and empathy for the unique details of a patient's life and illness. Second is representation, the ability to write or recount a story that captures a patient's lived reality. And then third, affiliation, building a common bond with patients or colleagues that leads to meaningful action on their behalf. Unlike traditional biomedicine, which often focuses strictly on fixing biological symptoms, that is, the disease, narrative medicine centers on the illness, the patient's subjective experience of suffering. To narrativize these subjective experiences, some of the core principles of narrative medicine also include narrative competence, the skill to follow a story plot, identify its metaphors, and understand the speaker's point of view, much like analyzing literature. Second is intersubjectivity, the idea that a medical encounter is shared creation between two people, doctor and patient, rather than an objective observation of a body. Third, narrative humility, acknowledging that a clinician can never fully know a patient's entire experience and must remain open and curious rather than assuming expertise over the patient's life. Now, this is the time to elaborate on these core principles of narrative medicine in greater detail. The first is narrative competence. Narrative competence is the multidimensional ability to acknowledge, absorb, interpret, and act on stories. While the term is broadly used in linguistics and development psychology to describe the ability to tell structured and coherent stories, narrative competence is most prominently recognized as the foundational skill of narrative medicine. Within narrative medicine, it enables healthcare professionals to provide more humane and effective care by deeply engaging with a patient's personal experience of illness. So, the core dimensions of narrative competence in healthcare that in a clinical context, narrative competence is categorized into four primary themes. First is narrative construction, that includes attentive listening to key words and non-verbal cues, understanding the patient's psychological and cultural context, and using representations such as metaphors to link illness to real life situations. Second, theme is medical relationship that includes building a therapeutic alliance through empathy, clear communication, and affiliation, that is, sharing the burden of disease with the patient. Third is narrative horizon that involves adopting a patient centered view that focuses on healing the whole person, including spiritual and mental peace, rather than just curing symptoms. Fourth theme is medical care and reflection that involves providing responsive care tailored to individual needs and engaging in self reflection to manage clinical uncertainty and avoid burnout. If we talk of developmental and linguistic context of narrative competence, we should discuss this like outside of medicine, narrative competence refers to the ability to construct stories that meet the following specific structural criteria. First is the macro structure that highlights the overall organization, including a clear plot, setting, problem, and resolution. Second is coherence that involves the logical, temporal, and causal connection of events throughout the story. And third is cohesion that involves the use of linguistic devices like because or after to connect sentences locally. In children, this competence begins developing around age 2 and is a strong predictor of future literacy, writing skills, and academic success. Now, you might wonder then why narrative competence matters specifically in relation to narrative medicine. Practicing with narrative competence allows professional to bridge the gap between biomedical facts and human experience. In medicine, it is linked to improved patient satisfaction, better adherence to treatment, and enhanced clinician well being by providing a framework to process the trauma and suffering witnessed in daily practice. If we come to intersubjectivity, we may say that in the health humanities, intersubjectivity refers to the shared psychological and emotional space between a patient and a provider, where mutual understanding and the co creation of meaning occur. It shifts the focus from a purely clinical or objective view of a patient's body toward a relational model where both parties are recognized as active subjects with their own intentions, feelings, and histories. So, the core principles of intersubjectives in health context are first, co construction of meaning. Instead of a physician simply diagnoses a problem. Intersubjectivity involves both the patient and provider working together to interpret the illness experience. Second is embodied connection, which it often relies on non-verbal cues such as touch, gaze, and rhythmic coordination, which allow for a pre-reflective understanding of the other person's state before words are even spoken. Third is relational reality. The truth of a clinical encounter is seen as something that exists between the two participants rather than as an objective fact held by one person. So let us take a closer look at some of these principles. The first core principle of co-construction of meaning in narrative medicine refers to a collaborative dialogical process where patients and providers jointly build an understanding of illness, moving beyond mere symptoms management to include the patient's lived experience. This approach turns medical interviews into shared, meaningful narratives, fostering empathy, improving diagnostic accuracy, and reducing clinician burnout. Now, let us see the core elements of co construction. The first is narrative intersection, and this is the dialogic space where the patient's personal story meets the clinician's medical knowledge. Meaning is not found in one or the other, but emerges from their interactions. Relational meaning making. Meaning is viewed as something relational and contextual rather than a fixed objective truth. It changes as the relationship between the patient and provider evolves. Third is emplotment. This involves taking a scattered event like symptoms, life changes, fears, and arranging them into a meaningful plot that explains the illness in the context of patient's life. Furthermore, there are some forms of co-constructed narratives under the intersection core principles of narrative medicine. Research identifies three primary ways these stories are built during a medical interview. First is co constructed chronology, jointly establishing the timeline of key health and life event. Co constructed elaboration, one party repeating or expanding on a detail provided by the other to deepen understanding. Co constructed interpretation, collaboratively assigning significance to a specific events or symptoms. Now, let us see what are the key benefits and challenges of co construction. Patients' agency. Effective co construction empowers patients to articulate their own accounts, leading to improved diagnostic accuracy and treatment adherence. Then comes shared decision making, and it forms the basis for shared decision making, where treatment plans are personalized based on the patient's values and life story. Then comes power asymmetry. A major challenge is the inherent power imbalance in medicine. Clinicians may inadvertently hide or override the patient's perspective with medical terminology if they are not narratively competent. Narrative mismatch, where conflict can arise when the clinician uses a scientific or paradigmatic mode focusing on general causes, while the patient uses a narrative mode focusing on particular life experiences. So, the following discussion provides a more nuanced explanation of these key benefits and challenges of co construction. First is patient agency. Now, patient agency refers to an individual's capacity to engage with, act on, and take responsibility for their state of health. It is critical component of patient-centered care. As it evolves, a patient's sense of control and ability to influence their own therapeutic process. Then comes the core manifestation of patient agency. Research highlights four primary ways patients reveal agency when facing health challenges. Firstly, through single dimensional rescaling, this aims at refocusing on remaining abilities. That is, a person with back pain finding joy in walking instead of running. Secondly, through multidimensional shifting. This involves moving the base of one's identity from a damaged physical body to the mind or spirit. Thirdly, through multidimensional embedding. This aims at balancing multiple aspects of life simultaneously, such as maintaining a professional identity while managing a chronic illness. Fourthly, through submission. This involves finding agency through effortful endurance or religious faith, viewing suffering as an existential foundation or a willful act under divine power. Now, let us discuss the barriers and facilitator of patient agency under co construction. The barriers to this benefit of co construction include paternalism, traditional hierarchical cultures where healthcare providers act as the sole givers of information and patients are passive recipients. Information gaps. This says about lack of access to understandable, relevant medical information, booklets, or clear explanations. Low health literacy, when the system fails to adapt communication to a patient's literacy level, it often blames the patient for non compliance. Coming to consequently the facilitators of this benefit of co-construction, which include shared decision making. In short, it is called SDM. Collaborative processes where patients and providers reach joint decisions based on clinical evidence and patient preferences. Digital tools, large language models, and conversational agents that improve access to personalized advice and health information. Then, patient advocacy groups, organizations that support patients in fighting for their rights and navigating complex insurance or treatment options. If we talk of a strategic importance of patients' agency, this tells us about promoting agency leads to several positive outcomes for both patients and the healthcare system. Firstly, it promotes improved health outcome. Engaged patients often have the better adherence to treatment and better long-term quality of life. Secondly, it promotes patient empowerment, shifting from being passive actors to co-designers who participate in a strategic healthcare decision. Thirdly, it promotes reduced cost. That is, better self management can decrease hospital readmission and unnecessary emergency visit. Then comes power asymmetry. The second major benefit and challenge of the co construction principle under intersubjectivity is power asymmetry. In healthcare, power asymmetry theory describes the inherent and often entrenched imbalance of influence, resources, and decision making authority between participants in medical encounter. While most commonly studies in the doctor patient relationship, it also manifests at the organizational and global governance levels. What are the key levels of power asymmetry? Power imbalances in healthcare operate across these three primary levels of social action. First is micro level, that is clinical interaction. This is the most direct form where the clinician holds medical knowledge, specialized language, and control over resources, prescriptions, referrals that the patient needs. This can lead to white coat silence, where patients hesitate to speak up or disagree even when they have serious concern. Meso level, which is organizational, institutional. Asymmetries within healthcare teams, such as medical dominance, where a physician's perspective may be prioritized over nurses or social workers. It also includes imbalances between strategic purchasers, insurers, and large provider monopolies. Third, macro level, that is global governance. This includes disparities in political and economic power between international actors, such as wealthy nations or philanthropic foundations, that is, the Gates Foundation, and lower income countries, which can shape global health agendas and research priorities. If we talk of mechanisms of influence or power asymmetry, the theory identifies several types of power resources that create these asymmetries. First is epistemic power, the authority derived from specialized knowledge. Clinicians often act as social arbiters who determine the authenticity of a patient's symptoms. Second is informational asymmetry, situations where one party has significantly more or better data than the other, often hindering effective shared decision making. Then comes symbolic power, prestige, and social status that allows certain actors to define legitimate health practices or visions of the world. So, what is the impact of power asymmetry on patient outcome? High perceived power asymmetry can negatively affect care by, firstly, reducing participation. Patients may adopt a passive good patient role, believing they should not undermine authority. Secondly, by increasing decisional conflict. When patients feel inferior, they are less likely to express personal preferences, leading to post consultation regret or uncertainty. Thirdly, by barriers to equity at a system level, these imbalances can entrench health inequalities by prioritizing the interest of powerful stakeholders over marginalized group. If we talk of strategies for mitigation of power asymmetry, well, we need to discuss modern healthcare models which increasingly aim to rebalance the dynamic. First is through shared decision making, that is SDM. This is a collaborative process where clinicians and patients exchange information and reach an agreement on the best course of action. Second is through reflexivity for clinicians, training providers to recognize their own power and adopt a fellow human being stance to foster trust and open communication. And finally, third is through patient empowerment, encouraging patients to take an active role, often supported by access to health information online, though this does not always eliminate the power gap. So let us look at this important strategy in greater detail. Patient empowerment is a transformative process in which individuals move from being passive recipients of medical care to active partners who take control of their health. It further involves developing the knowledge, skills, and confidence to make informed decisions and manage chronic conditions effectively. So, some of the core components of patient empowerment are the World Health Organization, WHO, and other global bodies identify several pillars essential to this process. The first component is health literacy. It refers to the ability to access, understand, and use health information to make critical decisions. That is to say, health literacy is healthcare, refers to how well individuals can find, understand, and use information and services to make informed health decision. Furthermore, it is now recognized as a two-way street involving both an individual's personal skills and the responsibility of healthcare organizations to make information accessible. So, some of the core components of health literacy include health literacy is more than just the ability to read. It involves a complex set of skills such as fundamental literacy, basic reading, writing, and speaking skills. Scientific literacy, understanding how the body works and basic scientific concepts like risk and probability. Civic literacy, navigate the healthcare system and participating in public health dialogues. Cultural literacy, understanding how cultural beliefs and values influence health decisions. Numeracy, the ability to understand and use numbers such as calculating medication doses or interpreting lab results. So, impact of health literacy on health outcome speaks of low health literacy is a stronger predictor of health status than age, income, or education level. It often leads to increased hospitalization. Individuals with limited health literacy are more likely to use emergency services and be uh, readmitted to the hospital. Higher cost in the US alone, low health literacy contributes to an estimated $73 billion in annual healthcare cost. Poorer self management, patients struggle to manage chronic conditions like asthma or diabetes and may have lower adherence to treatment plan. Safety risk, misunderstanding discharge instructions or medication levels create significant patient safety hazards. Organizational responsibility and strategy for health literacy. The Healthy People 2030 initiative explicitly defines organizational health literacy as the degree to which organizations equitably enable individuals to navigate the health system. So, if we talk of key strategies for healthcare providers, include universal precautions, assuming all patients may have difficulty with complex information and simplifying communication for everyone. Teach back method, asking patient to explain back the information in their own words to confirm understanding. Plain language, avoiding medical jargon and using everyday words. Visual aids, using pictures, drawings, or models to support verbal instruction. Ask me three, encouraging patient to ask three specific questions. What is my main problem? What do I need to do? And what is this important? Why this is important? The second component of patient empowerment is self efficacy. It refers to an individual's belief in their own capacity to execute behaviors and specific health outcomes. And the third component is shared decision making. As discussed before, this refers to a collaborative process where patients and providers discuss treatment option, risk, benefits to reach an agreement based on both medical evidence and patient values. Finally, the fourth component of patient empowerment is facilitating environment. This refers to a supportive healthcare culture that respects patient agency, values their input, and reduces hierarchical barriers. Benefits of empowerment for patient and system. Well, empowerment is linked to significant improvements in both personal health and overall system efficiency, which includes better clinical outcomes, and this encompasses improved self management of chronic diseases like diabetes and hypertension, which leads to more favorable treatment results and higher adherence rate. Second is higher satisfaction, in which patients who feel heard and involved report increased trust in their providers and higher levels of satisfaction with their care. Then comes system efficiency. Proactive patients often require fewer hospital readmissions and help optimize the use of healthcare resources, potential reducing long term cost. Then, patient safety. Informed patients are better equipped to identify potential medical errors and navigate complex transitions. It is high time to know about challenges and criticisms of patient empowerment. While widely praised, the concept faces practical and theoretical hurdles. The first is vulnerable populations. Disparities in digital access, language barriers, and socio-economic status can prevent marginalized groups from fully participating in empowerment initiative. Second is provider resistance. Some healthcare professionals may perceive an e-patient, empowered patient, as a threat to their traditional authority or expertise. Not all patients want control. Some individuals, particularly those with advanced or life limiting illness, may prefer to delegate decisions to their doctors or family members to reduce the psychological burden. Risk of burden. Critics argue that empowerment can sometimes be used to shift the responsibility for care and outcomes from the healthcare system onto the patient. If we talk of emerging trends of patient empowerment component, the landscape is shifting towards even higher levels of involvement. The first is patient design. Moving beyond mere participation, patient design involves patients as executive partners in designing healthcare services, tools, and research. Then, digital drivers, technologies such as artificial intelligence, wearable devices, and telehealth are providing patient with real-time data and personalized insight, further fueled by increased access to electronic health records. That is all for this lecture on introducing narrative medicine. We will discuss the next core principles, which is narrative humility, in the following lecture. Thank you very much.